My talk is entitled Mothers, Childhoods, and the Intergenerational Transmission of Mental Health Risk, Epigenetic and Behavioral Pathways. So first, I'll describe the problem of intergenerational transmission of mental health risk that I'm aiming to address. Then I'll explain why I'm interested in mother's childhood adversity as the exposure of interest for the next generation. Then I'll talk about two potentially interlocking pathways of intergenerational transmission that I'm examining in my research, one biological, mother's childhood adversity and DNA methylation, and one behavioral, mother's childhood adversity and early caregiving sensitivity. Finally, I'll talk about two future directions in this work, looking more deeply at the interactions between these two pathways and testing whether perinatal interventions can impact these pathways. Defining the problem. So we know that if your parents or your grandparents had a mental disorder, you're up to twice as likely to have one yourself. We also know that this increased risk is not only genetic. Estimates of genetic contributions of intergenerational risk for depression, for example, can be up to 40%, so considerable, but only part of the story. Why is this important? Mental disorders are among the leading contributors to disease burden globally. So because of the scale of the problem, prevention is imperative alongside treatment efforts. The perinatal period is considered to be particularly important for intergenerational transmission because of plasticity in the developing fetus and infant, as well as the possibility of a state of metaplasticity, where in utero exposures influence susceptibility to later environmental conditions. So why am I interested in focusing on disadvantaged groups? Associations between adversities, biological or behavioral mediators, and then detrimental fetal or infant outcomes may have different magnitudes or different relative strength when the risk factors like poverty or violence are more severe. So it's important to study these intergenerational transmission processes in groups exposed to high degree of adversities, not only because they're the groups most in need of services, that's where the burden is the greatest, but also because correlations may be detected in these groups when they may not be, particularly in small samples of more privileged groups. This might be particularly important for small effects in the perinatal period that could be important at a population level. And if interventions can affect these small effect sizes, they could potentially have big impacts on prevention over the life course of the offspring. Mother's childhoods as the first exposure. In the field of developmental origins of adult health and disease, or DOHAD, particularly in the last couple of decades, increasing research has focused on the effect of in utero exposures, for example, maternal depression or anxiety, stress, smoking, diet, exercise, on infant outcomes, and that's often birth weight or gestational age at birth, but also increasingly indicators of aberrant neurobiological development, including epigenetics, brain architecture through MRIs, scales of early infant cognitive and motor development, etc. However, in the last 5 years or so, there's increasing recognition that exposures happen even earlier than conception. And there's been a focus on mother's childhood adversity or trauma and intergenerational effects. But the pathways by which these intergenerational effects of mother's childhood adversity are transmitted to the next generation are not yet clear. So looking at biological and behavioral pathways. My KR1 research is delving into that potential intergenerational transmission in the perinatal period. And following animal research from Michael Meany's lab and others, I'm focusing on two potentially interlocking pathways, one at the level of genes, so mother's adverse childhood experience affecting DNA methylation in the mother and or infants, and one at the behavioral level, mother's adverse childhood experience impacting early caregiving. Animal models have shown that both early life stress and maternal caregiving, so in rats that's primarily licking and grooming, causes DNA methylation-induced changes in the expression of genes in brain regions that regulate stress activity. And these epigenetic changes can be transmitted from one generation to the next. Importantly, these studies have found through cross-fostering that these changes are reversible, meaning that the impacts aren't set in stone and they're amenable to intervention. So I'm very interested in how these findings translate into humans, and I've designed my KO1 research to start to examine some of the possible components of these pathways in humans. Based on work that's been done in animals, the theory is that childhood adversity or trauma acts as a toxic stress, dysregulating the stress response system through interlocking biological mechanisms, including DNA methylation and stress response related genes. In the case of a girl child, when that child grows up, if she becomes pregnant, these biological changes can then be passed on to her offspring. As a side note, animal models suggest transmission is also possible through the male germline, but I'm not considering that in the research that I'm currently doing. On the other hand, adversities may also impact early mother-infant relationship quality through a behavioral or psychological pathway, maybe learned caregiving or relationship skills or depression, anxiety symptoms. We know that mother-infant relationship quality is highly correlated with attachment style, which is a predictor of mental disorder risk. So both the biological and the behavioral effects of childhood adversity create developmental trajectory in the offsprings that are characterized by dysregulated stress response, ultimately contributing to higher risk for mental disorders. So that's the theory. And then in my work, this is the conceptual model under which I'm working. The boxes are the concepts that I'm measuring in the cohorts that I'm analyzing, and the circles are unmeasured theorized constructs. So again, the idea is that childhood adversities cause stress-induced biological alterations, which manifest on one level as DNA methylation patterns that can be observed during pregnancy. The childhood adversities also lead to increased prenatal distress and decreased quality of maternal caregiving. And all of this recapitulates in the next generation with biological alterations in the fetus and infant, which compromise cognitive and emotional development, increasing subsequent risk for mental disorders. And this biological alteration can already be seen in the newborn at the level of DNA methylation. Just as a note, because of the limitations of data availability timing in the cohorts I'm using, I'm not currently looking at the methylation pathway and the caregiving pathway in the same data set. So they're actually in two different data sets, but I'll go into that. So the epigenetic pathway. Epigenetic intergenerational transmission theory says that environmentally induced changes to genes can be passed on from the index generation to their children, grandchildren, even great-grandchildren. As a specific case, transgenerational transmission posits that the transmission happens even without continued adversity in the future generations, although we know that in reality that there usually are continued adversities in subsequent generations. So I'm not examining transgenerational transmission, but my work does try to isolate intergenerational transmission by examining DNA methylation in newborns before the external environment exerts an influence. Still, this could result from recapitulations of environmental conditions in utero rather than pure epigenetic inheritance. Looking through the literature, we found that while there is increasing evidence in support of intergenerational epigenetic transmission in animal models, so far there's very little evidence in humans, partly because of the scarcity of large longitudinal studies that are well equipped to test this hypothesis. So this we published in 2018. We identified several ideal study design features that would help human studies test this theory. Prospective study designs, ideally collecting data on maternal childhood adversity in childhood. Data on offspring during the perinatal period to isolate any biological transmission effects before the external environment exerts an influence. Studies in minority and disadvantaged groups for the reasons I mentioned earlier. And finally, large sample sizes in order to detect potentially small effects, particularly for genome-wide analyses, which are important for looking more broadly across the genome to detect effects. This review article came out in 2020 after the review that we had written, but we see that there are still many of the same limitations in terms of study designs. Most are cross-sectional, many are candidate gene studies, and the sample sizes are mostly quite small. But the most striking gap in terms of the focus on the perinatal period is that there were no studies looking at mothers' childhood adversities and DNA methylation in newborns or infants before the external environment begins to exert its effects. Since that review in 2020, there are actually 2 studies published that do look at mothers' childhood experiences and newborn methylation supporting intergenerational transmission, but these studies do have limitations. They're both candidate gene studies. They both have small sample sizes, and they both use retrospective reports of childhood trauma. So I'm aiming to contribute an analysis that surpasses some of these methodological limitations. This is using data from the Avon longitudinal study of parents and children, ALSPAC, which is a longitudinal birth cohort study of all births in the Avon district in the UK from 1996, I believe. I'm using a subset of the data called the Accessible Resource for Integrated Epigenetic Studies, ARIES, that includes methylation data on 1,000 of those mother-infant pairs. So I'm conducting a genome-wide association study of mothers' adverse childhood experiences and DNA methylation during pregnancy, using peripheral blood from pregnant women and infant cord blood. And we're testing prenatal depression and anxiety symptoms as a mediator. So back to the conceptual model, those dark red arrows are the ones we're testing in this part. For the DNA methylation pathway, we're looking at mother's childhood adversities to DNA methylation using peripheral blood during pregnancy, and then maternal prenatal DNA methylation to newborn DNA methylation from cord blood, and maternal prenatal anxiety and depression symptoms as a potential mediator of the relationship between mother's childhood adversities and newborn DNA methylation. This study has been pre-registered in the Journal of the American Academy of Child and Adolescent Psychiatry, and there's a summary of the study published there. And we have just gotten access to the data and will be performing the analyses shortly. I was hoping to have results, but it took a really long time to get the data. The other pathway I'm examining is maternal adverse childhood experiences to early in mother-infant relationship quality. This meta-analysis published in 2019 found a small but statistically significant association between maternal exposure to childhood maltreatment and parenting behavior. But there was some heterogeneity in the effects. Moderator analyses found that effect sizes were larger when parenting measures involved relationship-based behaviors or negative, potentially abusive behaviors. When samples had a greater number of boys compared to girls, so there's evidence for effect moderation by offspring sex, and in older versus more recent studies, maybe a study quality issue. Still, there are limitations to the study designs that comprise that systematic review. Many of the studies are in samples with relatively low prevalence of adversity or trauma. Some of the studies that are in more disadvantaged populations have quite small sample sizes. So one has 45, another 31. And finally, almost all entail retrospective reports of maternal childhood adversity, which we know are not highly correlated with prospective reports. So again, I'm aiming to address some of these limitations in examining the association between maternal childhood adversity and mother-infant relationship quality. And I'm doing this within the context of the Boricua Youth Study. The BYS is a longitudinal study of over 4,000 Puerto Rican youth in 2 different contexts, the greater San Juan area in Puerto Rico and the South Bronx, New York. And these children have been followed since 2000. And the original child participants are now having their own children. This birth cohort is currently funded through the NIH's Environmental Influences on Child Health Outcomes, or ECHO, consortium study. This data set does include prospective reports on childhood adversities. And we are adding original data collection to this study by collecting caregiving videos from a subset of this birth cohort. So back to the conceptual model for the caregiving pathway, these are the correlations we're analyzing in the ECHO BYS data set. Again, in the dark red, mother's childhood adversities to mother-infant relationship quality. and maternal prenatal anxiety and depression symptoms as a possible mediator of the relationship between mother's childhood adversities and mother-infant relationship quality. So we're collecting video recorded maternal caregiving observations within the ECHO-BYS study. We're aiming for a sample size of 200, about 100 from each site. Infants are between 2 and 6 months old. The caregiving videos are about 10 minutes. We ask the mother to change the baby's clothes and diaper, and then interact with the baby as she normally would. Research assistants were going to the participants' homes, but because COVID halted that data collection, we switched to a remote procedure whereby we call the woman via WebEx on her cell phone, and she sets up her phone as a camera in her room somewhere for the caregiving recording. The session is recorded and sent securely to the WebEx cloud, where we download it securely to the study server. So that's been working pretty well. Just wanted to give you a little bit of a flavor.
Funcionando bien. Porque como hemos estado tanto tiempo encerrados. Caleb, mira, jirafa. Mírame, Caleb, mira. Pulpo. Caleb. Pajarito. Caleb. Caleb. Mira. León.
So that just gives you an example and a sense of what those videos look like. The emotional availability system will be used to code the videos. EA examines emotional exchanges between caregivers and their children. It's a dyadic system, meaning that it assesses not only the mother's sensitivity toward the infant, but also the quality of their emotional exchanges. So to that end, the system assesses 4 caregiver dimensions: sensitivity, structuring, non-intrusiveness, and non-hostility, and 2 child dimensions: responsiveness and involvement. So the caregiver can't really look sensitive if the child is not responding. They really have to be working as a dyad, and so it assesses the quality of the relationship and the interactions. There are dimension scale scores and also an overall scale score of 0 to 100. These scales have been validated within a broad spectrum of contexts, including samples with children from infancy to middle childhood. So it's very flexible, low and high risk community populations and clinical samples. And the scores are highly correlated with attachment. So just to give you kind of a sense, in that last video, the mother was being a little bit didactic with such a young baby, with really trying to emphasize the names of each card. The baby was losing interest and wasn't really engaging with it, but she wasn't changing her tactics, so they would be marked down for that reason, just to give you a sense. But that's clearly not a problematic relationship, or it wouldn't be in the lowest category, but they wouldn't have the highest scores either. So there are 2 main next steps I'm planning for this research. The first is studying dynamic interactions between DNA methylation and caregiving sensitivity in humans, of course. So when the methylation data are available from the ECHO-BYS study, I hope to look at the 2 pathways together in the same sample. And as an important side note, moderation by genotype also needs to be considered, and is something I haven't yet incorporated. And finally, and very important from a public health perspective, testing whether interventions can impact these pathways. As I mentioned before, there are some key reasons to consider the perinatal period as a unique intervention point. It's a time of extended contact with the health system, which in many low resource settings doesn't happen in other life stages. So that's a unique opportunity. There's substantial evidence for special plasticity in the fetus and developing child. And it's an important opportunity to reach at least 2 generations. An intervention can impact parents by supporting them and improving their own mental health and physical health outcomes. And it can simultaneously affect early neurobiological development trajectories. And considering intergenerational transmission, it has the potential to impact future generations as well. To give an idea of just some kind of perinatal interventions I might be talking about, here are a few. Thinking Healthy is a cognitive behavioral therapy-based perinatal intervention that was originally developed in Pakistan and has been implemented in several low and middle income countries. It's now endorsed by the World Health Organization, and a manual is available online. Mom Care is a brief interpersonal psychotherapy-based intervention during pregnancy to prevent perinatal depression. This comes from Nancy Grote and colleagues at the University of Washington. PrEP, Practical Resources for Effective Postpartum Parenting, is a brief prenatal intervention co-located in obstetric care services that uses mindfulness and parenting skill building to prevent postpartum depression. That's being implemented by Catherine Monk and colleagues at Columbia OBGYN. And the Nurse Family Partnership is a nurse-delivered home visiting program to support first-time at-risk parents to improve child outcomes. And that's been implemented in a number of locations in the US and in other countries. Here's an example of one of the only studies that has examined DNA methylation effects of a perinatal intervention. This was a long-term follow-up study of the Nurse Family Partnership intervention. But we see that these effects were examined much later when the offspring were young adults. So I'm interested in examining the early effects of perinatal interventions in terms of both mother-infant relationship quality and DNA methylation. And going back to my roots in global mental health, I actually did my MPH at the University of Ghana. And as Emily mentioned, my doctoral work was in global health and population, where I conducted field work primarily in Rwanda. I'm developing 2 projects in low resource settings outside of the US. The first, this is an R34 application I just submitted in February. It involves trauma-sensitive obstetric care for mother-infant mental health, a randomized controlled trial. It involves implementing a trauma-sensitive obstetric care intervention within prenatal care in a public hospital in Buenos Aires, Argentina, and assessing effects in terms of oxytocin, including oxytocin methylation and mother-infant relationship quality. And the second one is an R1 application I'm submitting in June, prenatal interpersonal counseling for depression and anxiety in Mozambique, intergenerational mental health effects. So this study will take place within a larger U19 grant in Mozambique. And that grant includes a large-scale mental health treatment implementation study that's providing community-based mental health services in 2 provinces in Mozambique. And this R01 application will focus on a subset of 500 pregnant women screening positive for common mental disorders, and will test whether an evidence-based interpersonal counseling intervention delivered prenatally affects newborn DNA methylation and maternal caregiving at 6 months. Then we'll also test whether those proximal indicators are correlated with infant stress response a little later in infancy. And the idea is that this study would be able to provide some evidence that an intervention that's being adopted and implemented by the Mozambique government, which the interventions in the larger parent study are, may have even more far-reaching effects than simply improving mother's depression and anxiety symptoms. So to conclude, I haven't even looked at the time. To conclude, I'd like to acknowledge that the work I presented today is part of my KO1 Career Development Award from the NIMH, entitled Mothers' Childhoods and the Intergenerational Transmission of Mental Health Risk in the Context of Adversity. My primary mentor is Catherine Monk in the departments of Obstetrics and Gynecology and Psychiatry at Columbia, and Cristiani Duarte in Columbia Psychiatry, and Andrea Baccarelli, who chairs the Department of Environmental Health at Columbia Mailman School of Public Health, are additional mentors on my K.